excision of the proximal fragment. The indications are in a communicated fracture and in delay union or the non-union of fractures in the upper half. So, in this diagram, there is a tension band writing, that is TWT, tension writing band, and this is a fracture olecranon. So, in the fracture of the olecranon, tension wiring band is useful to treat the fracture. If the patient is greater than 50 years of the age and is not involved in the heavy work, this method is useful only if enough of the olecranon is left to form a stable base for the trochlea. So thus it is not indicated when comminution extends as far as the corona. So combination of intramedullary pin or the screw and the tension band. So the countered plate and the screw are indicated in communicated fractures with the bone loss where the tension band writing cannot be done. Then the distinguishing facts are reoperation rate after the tension band writing in olecranon fracture is high at 71.7% due to the backing out of the KY. Then the complications of these is non-union of the fracture, osteoarthritis of the elbow, tricep insufficiency, and restricted movement of the elbow are the common complications of the fracture olecranon. When do you consider the olecranon fracture as taken? If after the reduction it does not separate, or if the separation does not increase with the flexion of the elbow to 90 degrees. The quick facts are treatment of the displaced olecranon fracture concisely. First is a avulsion fracture in this TBW or LS, then in transverse fractures TBW and LS, and in transverse fracture with the plate and the screw with the bone grafting. So there is a oblique fracture, then LS or plate is useful in comminution, excision or plate or TBW is useful. Then in the fracture dislocation wire LS plate, TBW tension band writing and LS, that is lat screw fixation, is useful. Then the coronoid fractures, in that fractures of the coronoid process of the ulna were earlier thought to be an avulsion fractures which involving the brachialis muscles. Of late, these notions has been dispelled as it is found that the insertion of these muscles is more distant. So interesting fact about the coronoid fracture is its presence indicates a significant trauma to the elbow, and it also points toward the possibility of the acute recurrent dislocation. So this is a type of the coronoid fracture. This one, two, three, radio. And this is the radiograph of the coronoid fractures. Here is the coronoid fracture. Then the mechanism of injury, that this fracture occurs due to the impact of the coronoid process against the trochlea following a fall on an outstretched hand. So classification of Regan and Mori, that type 1 in that avulsion fracture of the tip of the coronoid. Type 2 in that fracture involving greater than 50% of the corona. And in type 3 there is a fracture involving the base of the corona. Then the clinical features is isolated fracture of the coronoid process are usually rare and are usually associated with the greater elbow trauma. Clinical features like pain, swelling, deformity, movement restriction of the elbow, etc. Depend on the extent of the damage. So Depend on the extent of the damage, the pain is severe or less. Then the radiograph that these fracture can be easily identified over a true lateral X-ray of the elbow. Treatment that those small undisplaced fractures can be managed conservatively with an above elbow plaster cast. Displaced fracture need open reduction and internal fixation with the screw or wire. Then capitellum fractures. In that, capitellum is the anterior portion of the lateral humeral condyle. This fracture is unique in being intra-articular always. Mechanism of injury shows that there is a fall on an outstretched hand with flexion or extension of the elbow, and the resulting shear forces through the radial head slices the capitulum. Then classification is based on the size of articulating fragment, and it is classified into the three types. Then type 1, in that these involve a large portion of the capitellum and a small chunk of the trochlea with the lace of subchondral portion. And in type 2, that is here only a large portion of the capitellum is involved with a huge chunk of the subchondral bone. And in type 3, there is a comminuted fracture. Then the vital facts about associated injuries with the capitellar fractures, that injury to the ulnar collateral ligament in 69% of the cases. The fracture of the head of the radius. So these are the associated injury with the capitellar fractures. These are the types of the capitellar fractures. In that, this is the A type 1 and this one, and this is a type 2, then this one. So the patient complained of pain and swelling over the lateral aspect of the elbow and the forearm movement are also restricted. The radiograph, a true lateral view of the elbow, is mandatory to accurately diagnose these fractures. The characteristic finding of this fracture is the presence of double arc sign, which is described by McCann over the X. In the treatment, there is undisplaced fractures can be managed conservatively by an above elbow plaster cast or slap for 3 to 4 weeks. So there is a displaced fractures need open reduction and internal fixation with mini fragment screw. So this is a radiograph. This is an X-ray which show a capitellum fracture here in the lateral view. Then, Physeal fractures. Knowledge of the secondary growth centers around the elbow is important to judge frequently subtle injury of the condyle of the humerus, and radiographic comparison with the uninjured site is mandatory. A comparative study of the lateral and medial condylar fracture of the humerus is presented here for easy understanding, and incidence is rare, is less than 5%. Epicondylar fracture in children are also called as the Granger's fractures. Then lateral condyle of the humerus, that is Jupiter fracture, accounts for 16.8% fracture of the distal humerus and can be associated with dislocation of elbow and fracture olecranon. Then classification in two ways, that is anatomical locations. In that type 1, fracture line lateral through the trochlea through the capitulotrochlear groove, and elbow is stable, that is high Jupiter fracture. And a type 2 fracture line extend into the apex of the trochlea and elbow is unstable low Jupiter fracture. Then the stages of displacement is that undisplaced, displaced, displaced and rotated. So in this diagram, that is in diagram A, you can see a lateral condyle fracture, that is undisplaced fractures, that is type 1. This is type 1 fracture and this is a type 2 fracture, that is lateral condylar fracture. In this, a radiograph showing a displaced and rotated lateral condyle fracture. Here, rotated and lateral condyle fracture. This is a diagram of displaced lateral condyle fracture. Displaced lateral condyle fractures. In that, you can see here is a displaced lateral condyle fractures. Yes, yes. This is a radiograph which showing the fixation of the lateral condyle fracture. Here, here you can see that is fixation. Here, fixation of lateral condyle fracture. So clinical feature shows that this consists of the little